So nursing diagnoses that you can use for your care plans: impaired skin integrity related to injury, such as pressure, or maybe related to restraints. That's why it's so important to check frequently. Risk for infection related to skin disruption, impaired tissue integrity related to poor perfusion or poor nutrition, and altered nutrition less than body requirements. All right, so a structured risk assessment is crucial after admission. National guidelines say this needs to be done, completed within 8 hours after admission. Many facilities have this in their policies. So you want to do a skin assessment to identify those at risk for pressure injuries, and that can include transferring between units as well to do a thorough head-to-toe skin assessment. You want to do a pressure point assessment, look at all the bony prominences, check behind the ears from oxygen tubing. The back of the head, maybe they were on sedatives in the ICU for a prolonged period of time. Check the back of their head. Sacrum, bilateral elbows, heels. And every time a patient's repositioned, it's a good time to check their skin and document. It's also very, very important to check under devices on admission too. I can't tell you how many times I take a device off and I find a pressure injury underneath it. So that's going to be a red flag to make sure you're monitoring that. Especially underneath ACE wraps, underneath braces, oxygen tubing behind the ears. I find pressure sores behind the ears quite often that come on admission, and ET tubes on their lips. Those, you can get a mucosal pressure injury to that area. So you also want to complete a risk assessment tool. For example, I know a lot of you are familiar with the Braden scale. You do not want to rely on this tool, this assessment tool entirely, though. You do want to use your clinical judgment based on risk factors for pressure injury. You want to reassess with any significant change in condition, such as surgery. So patients are in awkward positions for a prolonged period of time in surgery, so make sure you do that head to toe after surgery as well, or if they become septic or any change in mental status. And repeat the assessment as often as required, dependent on the individual's acuity. Refer to your policy. But the 2016 pressure injury prevention points do say that acute care should be every shift. Long-term care is weekly for 4 weeks, then quarterly, and home care is at every nurse visit. You want to identify those at risk and initiate preventative strategies and a prevention plan or care plan. Do assess activity or mobility limitations and skin status, and you want to consider bedfast or chair-fast individuals are at risk for pressure. Also, those with existing pressure injuries, they're at risk for additional pressure injuries. And assess skin prior to discharge as well. So once again, it's good practice to have another individual, another nurse with you to determine whether it is pressure or not, or talk with the patient or family to understand what truly the cause is of the wound. We're going to go over predisposing skin risk factors now. You want to keep in mind risk factors in order to utilize prevention strategies as necessary. So risk factors: perfusion and oxygenation. So inadequate blood supply can decrease supply of nutrients to the injured area. Poor nutritional status, so they need vitamin C, protein, or zinc. A lot of times I'm educating my patients to make sure they're eating their protein. I can see a huge difference in healing when they're not eating an adequate amount of protein. I don't see a decrease in measurements. I don't see granulation tissue forming. The wound bed looks pale red, so make sure you're encouraging them. Increased skin moisture or generalized edema is a risk factor for breakdown. Increased body temperature. Infection increases the inflammatory response and tissue destruction. Advanced age requires a longer time for epithelialization, and they have more fragile skin. Sensory perception, sitting in a chair, having no sensory of pain could be a risk factor. Hematological measures, general health status, poor general health, they have absent healing factors. Decreased mental status, or not aware to reposition, so make sure you're reminding them and documenting that you're repositioning. Incontinence, and pH of the urine and stool can be caustic to the skin and cause them to break down. Medical devices, friction or shear can cause tissue trauma, or mechanical friction can destroy granulation tissue. Immobility and inactivity, limited activity, you want them to encourage them to get up and move to decrease their risk. for breaking down. Additional predisposing risk factors. Drugs such as corticosteroids and chemotherapy can depress formation of granulation tissue and can impair phagocytosis by the white blood cells. I wanted to share this research as well. According to Cox and Roach, vasopressors have been found to contribute to pressure injury development. A retrospective correlational design involving 306 medical, surgical, and cardiothoracic intensive care unit patients received vasopressor agents during 2012. It was found that vasopressors such as norepinephrine and vasopressin contributed to pressure injury development. So there should be a heightened awareness to prevent pressure injuries when patients are utilizing these drugs. And at times they can be unavoidable due to the vasopressor's effects. Maybe you need to reposition more frequently with these patients, maybe every hour, monitor them more closely. Obesity, they decrease blood supply in the adipose tissue. Diabetes, hyperglycemia can impair phagocytosis and reduce oxygen supply and nutrients secondary to vascular disease. Anemia, decreased oxygen perfusion, decreased blood supply. Smoking, nicotine is a vasoconstrictor, can impede blood flow to the healing areas. Wound debris or necrotic tissue can delay healing as well. All right, I want to go over dressings as well. There's many different types of brands out there. You decide a dressing according to the depth, size, and amount of drainage. When selecting a dressing, it is important to pick something that can absorb the drainage, if it's cost effective, and whether there is infection in the wound. So it's necessary to keep a wound moist rather than dry, like I said, for reepithelialization to occur. Always label and date your dressing. Many of these dressings can be used for what we're going to talk about, prevention and treatment of wounds or pressure injuries. You do, according to national guidelines, you need to assess pressure injuries at every dressing change. And follow manufacturer guidelines, especially for frequency, or check your policy. So gauze. A moistened gauze is often used to fill wounds. You do not want to tightly pack it too tightly where it can cause damage and cause it to become more deeper. It's important to maybe, if you can use a single strand for easy removal and change according to the amount of drainage. And I usually say leave 1 to 2 inches out for easy removal. Non-adherent is minimally absorbent. You do not want that to adhere to the, if you don't want a dressing to adhere to the wound bed, you want to use a non-adherent dressing. Maybe someone with pain, with removal of dressings, maybe I need to use a non-adherent dressing with them. Or maybe for patients with skin tears, that fragile skin, I'll use a non-adherent dressing. So examples, Vaseline gauze, Zeroform, Adaptic can help with that. Transparent films. Semi-permeable, they do permit gaseous exchange between the wound and environment. So examples, Opsite, Tegaderm, these can also help prevent friction as well. You can use these as a secondary dressing over the filler dressing, over the filler dressings that are filling dead space. Hydrocolloids, this is an occlusive dressing. This does not allow oxygen exchange. It does help with autolysis, which we'll talk about in a little bit. So examples, Duoderm is an example. This can prevent friction. A lot of times I do not use these on lower extremities, on the feet or the toes, because it does create an occlusive environment, a warm, moist environment. So I wouldn't want to put this on the toes over a diabetic ulcer, or if they have arterial issues, because they can be at risk for infection. And according to national guidelines, hydrocolloids can be used for stage 2 pressure injuries or shallow stage 3 non-infected wounds. Hydrogels are used to moisten a dry wound for a moist wound environment. An example is Aquacite. Calcium alginates. This is a dressing in the form of a pad or ribbon. This is derived from seaweed, and this absorbs moderate to heavy drainage. So examples, Aquacel or Seazorb. So that can treat moderate to heavy drainage. Foam dressings can also absorb moderate to heavy. Examples are Aleve, Hydrazorb, Mepilex, and that can also help with preventing friction as well. You can also use these under devices. on the heels, and then 2016 guidelines do say too, if the patient's elevated above, if you can't keep them less than 30 degrees and they want to stay above 30, you place a Mepilex dressing or a foam dressing to the sacrum. You can use these for stage 2 or shallow stage 3 pressure injuries with the foam dressings. Antimicrobials. Many dressings are impregnated with iodine or silver. Examples, Silvadene, alginate silver, Ioban. This can treat an infection locally or prevent it. So according to national guidelines, silver impregnated dressings can be used for pressure injuries that are infected or heavily colonized. There's also honey impregnated products as well, and these can be treated for stage 2 and 3 pressure injuries. You do want to make sure the patient's not allergic to the honey, and there's a lot of research out there regarding that it does have antimicrobial properties as well. So wound care debridement. I want to go over the different types of debridement. Debridement is done to remove devitalized tissue from the wound bed. It's only performed when there's adequate perfusion to the wound, or you need to debride biofilm or any type of contamination. So the first one is sharp surgical debridement. This is done by a surgeon to surgically or manually remove the necrotic tissue utilizing instruments to cut away devitalized tissue. So a lot of times this is completed in the presence of infection by a surgeon, and it may be urgent. Conservative sharp debridement is something I do. This is completed by WOCNs or specially trained individuals based on local legal regulations, which I stay up to date on. I do use caution in the presence of immunocompetence patients, poor vascular supply, and if they have lack of antibacterial coverage due to sepsis, for septic patients. Contraindications, I won't debride if they're on anticoagulant therapy or have any bleeding disorders, and I will not debride on stable eschar and ischemic limbs. So mechanical debridement, this has been done for decades. This allows a dressing to physically be removed in order to remove devitalized tissue, or it's hydrotherapy, which is also mechanical debridement. This is wound irrigation, whirlpool, or ultrasound therapy. Enzymatic debridement, this is an application of a proteolytic enzyme to a wound to accelerate controlled digestion and removal of necrotic tissue. So example, Santal has the enzyme called collagenase that can digest the collagen in necrotic tissue. And it's a selective enzyme, so it won't harm good tissue. Autolytic debridement. This is a process by which the wound bed clears itself of debris using the body's own fluids, their own drainage, own macrophages. White blood cells can help digest the necrotic tissue. So that's an example with the hydrocolloids or Duoderm to create that occlusive environment for that. There's also larval debridement. This is maggot therapy as an example. The use of maggots to debride necrotic tissue. So research shows that maggot therapy reduces the number of pathogens, reduces odor, and increases the rate of healing. So there is dressings out there that do contain them in a dressing, and they are sterilized. Okay, wound care cleansing. Cleanse at each dressing change. You want to cleanse with water suitable for drinking or normal saline. You do want to use aseptic technique. It's not necessarily a sterile technique, it's a clean technique when cleaning. You want to utilize antimicrobial solutions to clean the debris or infection or any bacterial colonization. You want to cleanse tunnels and undermining with caution. Irrigation solutions can be used to supply sufficient pressure in order to remove the debris and bacteria. However, you don't want too much pressure where it can drive the bacteria into the tissue. And you do want to always cleanse the surrounding skin, the periwound. All right, surgical flaps for pressure injuries. Does anyone have any experience with flaps? Raise your hand. Okay, a few. Okay, so a surgical flap is where usually a plastic surgeon fills a defect. So they're repairing, let's say, a stage 4 wound. A lot of times I see these done on the sacrum. And what they're doing is basically rotating the various layers of tissue and muscle, blood vessels, and they're pretty much stretching that over the defect on the sacrum where the wound was to help repair that area. So you have to keep in mind with these type of wounds or these incisions, that incision, since they're stretching it, that incision's very tight, it's very taut. So you have to be very careful with these incisions when you're handling these patients. Make sure you're teaching your other coworkers and CNAs as well when you're handling these patients, when you're rolling them. Make sure you're, a lot of times we like to grab their hip when repositioning them. You do not want to do that with these patients because you could actually put tension on that suture line and it could bust open, it could fail very easily. So a lot of these patients are on, my experience, are on air fluidization beds for about 6 to 8 weeks bed rest in order for that flap incision to heal properly. A lot of times they're not supposed to follow your surgeon guidelines, but a lot of times they are not to bend at the hips. They're supposed to stay less than 30 degrees. And they're on that air fluidization bed to decrease shear and have microclimate control as well. And also, especially in the OR, you want to lift these patients rather than slide them. You don't want to put them on a slide board because you can fail the flap. So you do want to avoid shear and friction to protect the blood supply to the flap. Also, a lot of them do have drains with these, and make sure you're recording the output accurately because that will help determine with the surgeon whether they can remove the drains or not. So do follow your surgeon's orders for dressing changes as well. Okay. So you do want to report signs of flap failure to a surgeon as well. So things to look for when you're assessing a flap is pallor, mottling, incisional dehiscence. Is there increased drainage from the incision? And this would be with any surgical wound as well. Edema or any bluish purple discoloration to the incision, which would indicate that there's a lack of blood supply to that part of the incision at risk for breaking down. There's also a sitting protocol per surgeon's orders normally as well. So that's usually done after the bed rest. And a lot of times they're wheelchair, if they were wheelchair bound before, they need pressure mapping done with their wheelchair cushion to ensure that they have proper support surface. And ultimately you want to educate pressure injury prevention with these patients after discharge because with flaps, they if they fail, there's a lot of times plastic surgeon, there's limited amount of tissue to be able to flap it again. So that's why it's so important to make sure you're handling these patients correctly. We're going to go over preventative skin care and prevention strategies now. I want to include some research. According to Marr and Lanker, a systematic literature review was completed and showed that pressure injury prevention for the adult population at risk for breakdown can importantly affect the budget of healthcare services. So expenses can be much higher when treating a severe pressure injury. So that's why pressure prevention strategies are crucial. So examples, you want to avoid positioning on areas of erythema because this redness is related to the body not totally recovering from repeated loading. Keep skin clean and dry. You want to use a pH-balanced skin cleanser. Studies have shown, according to Dimitri and Lanker, an association between the moisture with incontinence-associated dermatitis and pressure injury development. So moisture increases skin vulnerability to pressure injury. You do not want to massage or rub areas at risk for pressure injuries because this can cause tissue destruction. You want to consider a continence management program, cleanse after each incontinence episode, and you can offer toileting, for example, maybe every 2 hours. Utilize a barrier product to protect the skin from moisture because, once again, moisture can increase risk for pressure injury formation. Utilize a skin moisturizer. You want to keep skin hydrated to decrease risk for breakdown. Therapies for pressure injury prevention. You want microclimate control, so you want to utilize a support surface such as a low air loss bed or an alternating low air loss bed to control moisture and to control the heat as it dissipates from the skin. Use incontinence pads that are compatible with the air bed. You want to allow the airflow to control the moisture. Do not apply heating devices to areas at risk for pressure injury because heat increases the metabolic rate and reduces the tolerance for tissue for pressure. Prophylactic dressings. You want to use prophylactic dressings maybe over skin from medical devices or areas of redness or friction or shear to prevent them from breaking down. Polyurethane foam dressings can be used over bony prominences like the heels and sacrum to prevent pressure injuries that are areas that are prone to friction and shear. Also assess the skin for signs of pressure injury formation at each dressing change or at least daily. You want to remove the dressing, look underneath to assess. So a lot of these dressings, polyurethane foam dressings, have a silicone border that you can uplift and look underneath and then replace without tearing the skin. According to national guidelines, fabrics and textiles, they suggest silk-like products rather than cotton fabrics that can help reduce friction and shear. There's also electrical stimulation. This creates muscle contractions and has been used on spinal cord injury patients on areas at risk for breakdown. Nutrition. So nutrition screening for patients at risk. You want to do this on admission. If there's a change in clinical condition, delayed wound healing. You want to use a nutritional screening tools for those that are at risk for nutrition. You want to consult a dietitian if they're at risk for malnutrition or if they have an existing pressure injury. So a nutritional assessment includes weight status. Identify significant weight loss greater than 5% in 30 days or greater than 10% in 180 days. You want to assess the ability of the individual if they can eat independently. Also assess the total nutrient intake. So you want to look at food, fluid, oral supplements, and enteroparenteral feeds. You want them to have an adequate protein intake, and this is determined by the number of pressure injuries, comorbidities, the overall nutritional status, and their tolerance to interventions. So a lot of times I'm consulting with the dietitian if I'm concerned about a wound healing. If it's not healing adequately or it's stalled, I'll talk to her a lot of the times to see what we can do to increase their nutrition. Also look at adequate vitamins and minerals, which a dietitian also looks at. So according to the new 2016 pressure injury prevention points, you want to consider hospitalized individuals at risk for malnutrition or be an NPO. You also want to assist individuals at meal times to increase oral intake as well. Repositioning and early mobilization. So you want to relieve or redistribute pressure over vulnerable areas. You want to avoid, once again, repositioning over areas of erythema because this can further occlude blood supply to the skin, which increases damage. You also want to use manual handling devices. You use a lift or transfer sheet to reduce friction and shear. You do want to lift, don't drag when repositioning. And you can use, for example, bed linen to assist with repositioning or even a trapeze to prevent friction. You can use a sling mechanical lift to transfer patients to the chair or wheelchair. However, you do not want to leave a sling underneath the patient. There has been research that does increase pressure to the sacrum and coccyx and can increase their risk for pressure injury development. You do want to ensure that patients aren't laying on devices like tubing, drains, or any other foreign objects like syringe caps, anything that's left in the bed. So monitor what's in their bed and make sure that you monitor the syringe caps and throw them out. Do not leave a patient on a bedpan for extended period of time. My rule of thumb, no longer than 15 minutes. Talk to your CNAs, so make sure there's a lot of communication. Make sure they're not leaving them on them and forgetting about them. So communicate so that they won't get pressure injuries. Mechanical loading and support surfaces. Again, reposition bedbound individuals at least every 2 hours. Chairbound individuals every hour. They need to you educate them to offload their sacrum in the chair every hour or assist them. You want to consider postural alignment when up in the chair or wheelchair. Ensure that their feet are on the ground or on a footstool so you don't increase the pressure to the sacrum or coccyx. You do want to teach chairbound individuals to shift their weight every 15 minutes. Patients that have mobility limitations cannot always feel that they need to shift. As you guys are all sitting there, you're subconsciously shifting your weight for comfort or to redistribute your weight. So make sure you're reminding them to shift their weight every 15 minutes. Utilize pressure redistributing mattresses and chair cushion surfaces for patients at risk. And use pressure redistributing devices in the operating room as well. All right. You also want to pad bony prominences, including the knees and ankles, with pillows or foam wedges from direct contact with one another when you're repositioning. You want to pad skin in contact with devices to prevent pressure. You also want to offload heels, according to national guidelines, with pillows under the calf for stage 1 or 2 pressure injuries. But then you can use offloading boots with any stage of pressure injury, 1, 2, 3, 4, unstageable deep tissue injuries. You do want to avoid repositioning patients directly on their hips or their trochanters. You want them in a sideline position, 30-degree lateral incline position. You can use your hand to check if their sacrums is offloaded off the bed. The head of bed should be at or below 30 degrees at the lowest degree of elevation, based on the patient's medical condition, of course. If they need to facilitate breathing or prevent aspiration or prevent ventilator-associated pneumonia, then semi-Fowler's position would be preferred in these situations. You also want to prevent friction from sliding down in bed. So you can, a lot of times I'll elevate the legs of the bed and keep their head of bed less than 30 to avoid them from sliding down and causing that friction or shear. Also, make sure you're documenting your repositioning. So if something ever did occur, the first thing the auditor is going to look at is, did you do everything you can to reposition? So make sure you're documenting. Now, if a patient's refusing, you want to do an informed refusal, which means you want to explain the benefits and risks of repositioning, make sure they understand, document that they verbalized understanding, and document that appropriately. And also tell your CNAs too, if a patient does refuse, they need to be going to the nurse and telling the nurse so the nurse can go back and educate the patient. Sometimes it's just a choice of wording. Sometimes they don't want to be directly on their side. Sometimes if I just say, we need to shift your weight a little bit, they're fine with that because they don't want to be directly on their side, which they shouldn't be anyways. Also, limit amount of linen and pads on the bed as well, once again, to allow airflow, make sure they're breathable. All right, we're going to talk about prevention of medical device-related pressure injuries. This is a common problem at many facilities. They have difficulties with this, so we'll go through a lot of examples. But the new definition for a medical device-related pressure injury is that it describes the etiology of the injury, and it results from the use of diagnostic or therapeutic devices. The injury usually conforms to the pattern or shape of the device. And you do use the staging system with these, with medical device related. So according to the national guidelines, you want to choose the correct size of medical device to fit the individual. You want to cushion and protect the skin with dressings in high-risk areas, such as the nasal bridge. You want to remove or move the device daily to assess the skin. Avoid placement of the device over sites of prior or existing pressure injuries. And you want to educate the staff on correct use of the device and prevention of skin breakdown. Also be aware of edema under the device and that there's potential for breakdown when there's edema. So this should be a red flag. Whenever I see a patient that is now edematous, I'm worried about the device on them if they have one. So make sure you're monitoring that closely. For example, I think this happened over a weekend. A patient went into fluid overload. They were septic, and so the devices that they had on did not fit properly anymore, and the family persisted that their TED hose and their Prayfo boots be placed. And they did end up breaking down due to the devices not fitting properly, and because they're dentists, they're going to break down very, very easily. And so they did end up with breakdown. So you do need to make sure that you're educating family as well, that it may do more harm than good, and also talk to the doctors too. A lot of times they are receptive maybe to DC the devices temporarily until the underlying cause is treated. So make sure you're communicating that as well. So we're going to go through each of these pictures and talk about prevention of these devices. So with ET tubes, make sure you're following your policy on how that can be repositioned. A lot of times they could be repositioned from the right side of their lip to the mid to the left. So follow your guidelines on how to prevent these sores on the lip. Trach ties. So with trach sites, a lot of times there's a lot of moisture around these areas, so they're going to be at risk for breaking down. They also need to make sure that, talk to your respiratory therapist as well. You should be cleaning underneath these frequently. Follow your policy, making sure they're clean and dry. You can place a foam dressing or a type of dressing to help control the moisture to help prevent breakdown. Retention sutures can be an issue too, especially if their abdomen is swollen. So with these patients, I'll look underneath the retention sutures to see if they're getting any redness, or if there's no redness, I'll still prevent if it's really tight against their skin and wedge, maybe alginate if there's a lot of moisture underneath them, or gauze, whatever I can do to pad underneath there. Sometimes I even have to call the surgeon if there's an issue with one of them. And depending on how long and if it's appropriate to remove one of them, I'll ask if I can remove one particular suture to relieve the pressure. So do keep that in mind. Now with this NG tube, this looks like it was strapped to the skin tightly and caused tissue necrosis, a deep tissue pressure injury. So do be aware of how you're strapping tubing to the skin. You really shouldn't be, because they can break down very easily. So do monitor that and rotate with these tubes, follow your policy on how you can reposition them to avoid these injuries. O2 saturation probes. A lot of times these are repositioned about every 2 hours. So every time you reposition patient, you can reposition the O2 probes so they don't get a pressure injury to those ears. So like we said, they can become a stage 3, stage 4 very easily in these areas. Oxygen tubing. So behind the ears, a lot of the time I see pressure sores, or I think on him it's around the chin. You can pad with a foam dressing underneath there. Or behind the ears, a lot of times I find pressure injuries behind the ears, stage 3 pressure injuries. Know that there's even tubing out there too that's soft and pliable that helps prevent these sores from occurring. Or a lot of times I even put moleskin around the O2 tubing behind the ears to prevent breakdown. Or you can put a foam dressing, whatever it may be, to just help offload that area if you're seeing redness. Okay, and then once again, the mask, CPAP and BiPAP mask. So make sure you're following policies and talking to therapy that underneath a mask that they have, that you're cleaning that properly as well, keeping it clean and dry. If you start seeing redness, you want to make sure you're padding that area appropriately to avoid injury to the bridge of the nose. So you can slide a thin foam dressing underneath the mask. There's also masks out there that put more pressure on the forehead rather than the nose. Or there's those fireman masks too that don't put any pressure on the nose at all either. So there's various devices available to them, but that's a way that you can offload, is supplying a foam dressing. So catch early before it's too late. Bedpan. So bedpans, once again, monitor how long they're on, encourage them to get off. I know a lot of them like to stay on, but make sure you're monitoring that. Arterial line. In this picture, it looks like maybe it was strapped to the skin too tightly. So once again, monitor how, if they're laying on a tube or if it's strapped to their skin, try to avoid that. For example, I had a patient that came to us on admission. The patient had a wound back to their foot, and the tubing was brought up along their leg and strapped with Coban. The patient also had arterial disease as well, and when I took off that Coban during the skin assessment, there was a large deep tissue pressure injury. So do be aware of that. And that's why it's important to remove these devices on admission as well to assess under them. Wrist splints. You can talk to your OT about proper care with them, but those should be removed during baths, during your skin assessment. Make sure their skin is clean and dry. If you start seeing redness, pad the area. Once again, catch it early, be proactive, and educate your coworkers, your CNAs, to make sure that they are cleaning properly with the baths. Okay. According to Clark and Black, a systematic review of the use of prophylactic dressings in the prevention of pressure injuries suggested that initiating a dressing for pressure injury prevention may help decrease the incidence of pressure injuries when utilizing medical devices, so especially with immobile ICU patients. So no specific dressing is proven more effective over another dressing. However, the National Pressure Ulcer Advisory Panel does recommend the polyurethane foam dressing. So use a prophylactic dressing under a medical device, and you want to consider managing moisture. You do not want to apply excessive dressings, though, underneath the device, as this can create more pressure. You also, like I said, keep it clean and dry under the devices, because moisture can alter the skin integrity and at risk for breaking down. Reposition the device if possible, and depending on the surgeon's orders, voice your concern as well to the doctors as well. See if anything else can be done. So if they have pain, that's an early sign. You want to catch early. If you start seeing any redness, any areas of friction, you want to make sure you're padding or placing a dressing to prevent the friction or pressure. TEDs or TED hose or sequentials, those should be removed during the bathing process. You want to avoid creases in the stocking, so make sure, especially if patients have peripheral vascular disease, they can break down very, very easily. So make sure you're educating everyone else too to avoid these from occurring. According to Shalom, a study showed that the full face mask had fewer incidences of pressure injuries and more comfortable for patients when receiving non-invasive ventilation. So make sure you're also educating your patient when they have a device to report any discomfort. If the device is too tight or too painful, it must be reevaluated for their fit or adjusted to prevent breakdown. So catch early. So does anyone have any examples of what they've done to prevent a medical device-related pressure injury? Anyone? No one today? Anyone?
You can get those gray things to go over oxygen tubing.
Yeah, to pad the tubing behind the ears, yes. Yes, to monitor behind the ears. Oh, yeah. Yeah, it's an indentation from the Foley tubing. You can pad that. Any other ideas? Okay, I have examples. Peg bumpers, sometimes those are sutured too tightly. So sometimes even doctors forget to have an order to remove those sutures. So talk to the doctors. If it's been a while, you can get those sutures removed. If it's not been a while, and a lot of those bumpers have indentations in it, so they can get several little pressure injuries underneath that bumper. So a lot of times you can wedge just like an alginate if there's a lot of moisture underneath there, wedge that underneath there, or gauze, whatever you have, in order to offload that area. ACE wraps, I can't tell you how many times someone comes on admission and I find multiple pressure injuries underneath these ACE wraps. What I do, I apply cast padding or cotton batting underneath these ACE wraps to avoid pressure injuries, which have been helping very much so. Braces, I've had to call physical therapy in to reevaluate a brace, or even the company to come back and refit them with the brace. C-collars. C-collars cause the rubbing a lot of times. They get a lot of moisture, so they can break down really easily. So do keep in mind you can pad those areas, or if it's from friction, maybe a Tegaderm to that area as well can help offload or prevent friction. All right, pressure risk assessment scale. So there's many different scales. I know you guys are familiar with the Braden scale, but there's also the Norton scale, which includes risk factors that they look at to determine whether a patient's at risk for a breakdown. or pressure ulcers. So they look at physical condition, incontinence, which is different from the Braden scale. Waterlow scale has many more risk factors. They look at sex, age, build, appetite, the nurse's visual assessment of the skin, mobility, continence, factors contributing to tissue, destruction, malnutrition, neurological deficits, major surgery or trauma, medication. And the Jackson-Cuban scale has other factors, weight, respiration, hygiene, or hemodynamic status, or some differences. So the most common is the Braden scale. Okay, so the Braden scale is a scoring system to predict who is at risk for pressure injuries. So the 6 subscales include sensory perception, moisture, activity, mobility, nutrition, friction, or shear. So the Braden score should not be used alone. You should also be looking at other risk factors, maybe the patient's overall status. Are they diabetic? Do they have a long length of stay in the ICU? Do they have peripheral vascular disease? Mechanical ventilation or any use of sedatives are going to make them at risk. So the scoring system with the Braden score example, very high risk is 9 or less. No risk is 19 to 23. So you can initiate Braden subscale interventions based on assessment ratings. So you want to develop a plan of care on areas of risk rather than the total score. So this is just an example of what some interventions could be. Your facility may have different. But so if the risk stems from immobility, then you may want to, you should do this with everyone, float heels off pillows or use offloading boots, reposition every 2 hours, shift weight in the chair every 15 minutes, and you use a pressure redistribution mattress. Nutrition, if it stems from nutrition, you may need a dietary consult. Maybe they're very thin or they eat less than 50% of their meals. You may want to initiate a foam dressing to the sacrum. They may not have wounds right now, but they have multiple risk factors. Maybe they need a chair cushion as well to prevent. And also encourage the dietary supplements as well. If moisture is an issue, barrier cream, perineal cleansing, incontinence pads, and keep them clean and dry. Friction and shear, if you can keep the head of bed less than 30, that would be ideal. Protect areas that are exposed to friction or shear. You can use a polyurethane foam dressing. You want to initiate for the high-risk patients. You do not want to wait until they break down. So be proactive and catch early, and encourage your staff once again to initiate prevention strategies and to identify these patients at risk. So pressure injury prevention with the bariatric obese patients. So you want to assess under skin folds because pressure can occur in areas of high adipose concentration, not just bony prominences. So, and also, once again, intertriginous dermatitis versus stage 1 or 2 pressure ulcers gets confused quite often. So once again, intertriginous dermatitis is that inflammation of the skin due to the friction and moisture of skin folds rubbing. You do want to assure the appropriate size of support surface as well. You want them to have sufficient room for turning so that they're not, so you are avoiding pressure against the railings of the bed. Chair cushions, you want to make sure they have the appropriate size. And also use a pillow or other positioning devices to assist with offloading the pannus or other skin folds to avoid skin-on-skin pressure. Pressure injury prevention with the critically ill. With these patients, they may require frequent small turns to allow sufficient time to stabilize vital signs. You want to allow reperfusion in individuals who can't tolerate repositioning. According to national guidelines, there's really very few patients that are truly unstable to reposition. However, if you can only do the frequent small turning, you should trial repositioning every 8 hours to verify if repositioning can be reestablished. And make sure they're on a proper support surface. And you may need to consider lateral repositioning. I know there's lateral rotation beds, but patients still need to be repositioned. You still need to offload their sacrum in these beds. And a lot of times these are used because it can assist with training the body to tolerate side-to-side turning. Pressure injury prevention in the operating room. So patients in the OR are immobile, so prevention is important. Risk factors during surgery include duration of time that they're immobile prior to surgery, time length of surgery, hypotensive episodes that can occur during surgery, low core temperature, and decreased mobility on post-op day number 1. You want to make sure the heels are offloaded and utilize appropriate support surfaces. So facial pads when they're in the prone position or on other bony prominences like the knees. They must document the patient's position during the surgery as well and document any anatomical areas under increased pressure during surgery and document the areas that are padded for prevention. Okay, patient or caregiver education. You want to educate the normal healing process to your patients or family members. Educate that they should see signs of healing of their pressure injuries within 2 weeks. And a care plan should be readdressed if no progress is seen. Teach signs and symptoms of infection and provide pressure injury prevention education prior to discharge as well. And document on the education. Take credit for what you educated them. To close, now that you guys are skin resource nurses, you can decipher various types of wounds and stage pressure injuries accurately, and also make sure you're educating your staff, your CNAs as well. Make sure that you're identifying risk factors and catching it early before it's too late, and to ultimately help decrease hospital-acquired pressure injuries at your facility.